Brilliant. We are live. So welcome to Time to Talk with Cognitive Sports Therapy. I am Dr. Claire Gilroy, and I am joined tonight by Dr. Gareth Corbett, who is consultant gastroenterologist based in Cambridge and also the clinical director of Digestive Diseases at Addenbrooke. And I have to say, Gareth, we've not really said this. I've never really met you, have I? But I think we have a lot of mutual patients, and I don't think that's that much of a surprise. There's a massive link, I think, between our mental health and our gut health. And I think that's why I was really keen to kind of get you on here tonight and have a bit of a chat about gut health. I don't know if you want to say anything more about who you are and your background. That's maybe...
Yeah, so I'm a kind of general gastroenterologist working at Addenbrooke's Hospital in the Nuffield in Cambridge. My subspecialism is actually in advanced endoscopy. So a lot of my NHS work involves treating complex endoscopic problems, that various things that we can do for patients. In my clinics, though, I see a lot of people that need good quality rapid diagnostic workup and a careful think about what to do with the results of those. I guess my biggest thing is that we see a lot of patients with symptoms like abdominal pains and alterations in bowel habits, bloating, and those sorts of things are very common to see. They can all be caused by significant physical disease, which is why the diagnostic workup is very important. But you do meet a lot of patients where all those tests are normal. And in that scenario, you have to think about what to do. I think a lot of the medical profession uses the term it's just IBS, and I find it an offensive term saying just, because actually, you know, you have this is something that most commonly affects people of working age. You talk to them about how it affects their work and their occupational abilities, and it clearly has a massive impact on being able to, you know, do a normal job. You know, you think about it, even so if you, as an example, I've got patients who do jobs where it's not possible to leave what they're doing to go to the loo, and yet their IBS symptoms mean that they sometimes are like, if I don't go to the loo now, there's going to be a problem. Whereas if somebody works in an office job where to get up from the desk and go to the loo, it's not as much of an issue. It doesn't impact on their ability to do their occupation and so on. While I appreciate the symptoms can impact their quality of life. So that, and I think that's why not sitting down at the appointment after finding all the tests are normal, the right thing to do is go, great news, your tests are normal, back to your GP. You know, that's that. And I think what ends up happening for those patients is you end up getting a lot of ping pong going on where, you know, they've had a load of diagnostic tests by a specialist who said, I can't find anything, bye-bye. And then they go back to a GP who goes, well, I sent you to a specialist because actually, you know, it wasn't just to do a workup, it was to get some advice on what else we might be able to do. Because even if you suggest to somebody in primary care, you know, GP colleague, a pathway of treatment that you can do, you know, at least that can be supervised and worked with in that setting. Or better still, in our current state of affairs, with post-COVID and everybody in healthcare finding it very difficult to give as much time to each individual patient as they might want to, sort of work out a way to do it, you know, yourself to a point where you've got some, you know, some successful management. So that's my view on those things. And what I do is a lot of you know, discussing how we can manage symptoms that are of a functional nature.
So what would be your sort of top tips for someone who has really debilitating IBS symptoms? Where are we at with advice?
So I guess the first thing to say is thinking about an explanation for what's going on, and I think that can be really helpful, and also an admission of the inadequacies of science in this area. So if you take diseases like cancer and inflammatory diseases like rheumatoid arthritis, Crohn's disease, that sort of thing, these diseases do either potentially lead to major surgery being required or cause mortality. They kill people, and so as a result, inevitably a huge amount of funding has gone into the research into those things, and we now understand, you know, cancers down to the molecular level. We understand inflammatory diseases down to the molecular level. But if you take diseases like fibromyalgia, irritable bowel syndrome, chronic fatigue syndrome, none of them kill people. They lead to an impact in quality of life, and none of them have got a blood test or a marker, pardon me, that we found to be able to know what to do with them, right? So actually, an admission from the medical profession to say we haven't got the science to be able to give you the same answer we'd give you if it were a pneumonia or a Crohn's disease or a bowel cancer or whatever.
Yeah.
But we do know that we have got some science. We do know with IBS, for example, that there is a massive interaction between gut microbiome and the symptoms that people have. What we don't have is a clinically validated stool test to do to be able to go, right, it's this mix of bacteria, this is what we do. Now there's loads of labs that you can pay 3-digit amounts for to get a readout of all your gut bacteria, but actually well, I don't mind patients doing that. You can do what you want, but actually we don't have the same tests in sort of normal healthcare to be able to sit down and go through these and go, oh, you need to have this antibiotic combination, or if you do this and that, it's going to work. So what we're left with is the medical literature on treating irritable bowel syndrome. And so what have we got? Well, we've got dietary management is the first one and the absolute hallmark. And the sort of starting point was the low fiber diet, which was written up in the late 70s, early 80s. Very well evidence-based that a well-followed low fiber diet will produce improvement in 65 to 70% of patients. And then we've got the low FODMAPs diet, which came out of Australia around 2009, 2010. And actually is an extension of the low fiber diet, just looks at other things that are fermentable. And the whole theory behind it all is that you have gut bacteria that are over fermenting things that you eat, i.e. they're producing too much gas, be it hydrogen, methane, hydrogen sulfide, whatever. And then that leads to stretch in the bowel. The gas expands, the bowel gets wider, and that's what kicks off sensory nerves in the bowel. So that's why people get cramps and things and why their tummies bloat up. But I think there may also be, although again, this is dodgy science, there may also be some neurotransmitters or something that the gut bacteria are producing during that metabolism, because I can't think of why else people should have pains with no source, and gut motility that goes crazy and all that sort of thing. So there must be something else going on that creates all of that side of things. So
it's tricky though, isn't it? So I then see people who've been put on those diets and they don't like them. I kind of then have that conversation a lot with patients afterwards going, I've been told to go on this FODMAP diet, but all the things that I enjoy, and they'll actually list things that are really, I would say you'd think are really healthy for them, they're not then allowed to eat. I mean, is that something that you can do for a period of time and then start to reintroduce foods again that you enjoy?
Well, that's the most important thing about the low fiber and low FODMAPs diets, is that they're like a medical treatment. Like an antibiotic, you prescribe someone an antibiotic for 7 to 12 days, right? As a course. This is exactly the same. It's normally 3 to 4 weeks of very strictly following the diet, and then you do a staged reintroduction of various foods over about 6 weeks. And we have got a early stages study going on of gut microbiome changes by low FODMAPs diets, and we know that you do get alterations in the gut bacteria makeup with the low FODMAPs diets, and some patients will walk in having done it strictly and found that they have got a massive improvement in their symptoms and they're able to reintroduce things correctly. I think the hardest thing is convincing patients to follow it to the T during the time they have to do it, and I think the low FODMAPs diet, people find the feedback I hear in the clinic is confusing. I'm not sure if I can have this or this and so on. So I've taken to referring all patients that are going to go onto a low FODMAP diet to a trusted dietitian that's got training in it to take them through it and be there to help answer the should I, shouldn't I with certain foods within it. That breeds much more success with that particular diet than the go and look it up on the internet approach. For the isn't there? Exactly. For the low fiber diet, there's it's much more easy to follow written advice for that, and you can find that in all sorts of sources. I've got the one that CUH use, Cambridge University Hospitals use on my website to have a look at. But I wouldn't recommend downloading and starting diets without some professional advice first, because like I said at the beginning, if you've not gone through a diagnostic workup, it is important to do that at least.
Yeah. And I guess it's slightly confusing as well, isn't it? Because I think most of us would have the thought that to keep our guts healthy, we should be eating fiber. So if we do kind of step into bowel cancer, fiber is a protective thing, isn't it, that we're eating?
Yeah, and I'm asked that a lot by patients, obviously. Yeah. But again, just to reiterate, it's a short-term medical intervention to sort of alleviate symptoms in the short term and create a gut bacteria change. And the diet is all based on 4 weeks of diet and then a reintroduction. And the low fiber diet actually teaches you the amounts and proportions of higher fiber food that you can eat before you start getting symptoms. So actually, and also very often the patients that are really symptomatic, they're eating vastly more fiber in their diet than they would need to prevent bowel cancer and heart disease. Okay, it's often the people with IBS due to that's coming on because of dietary choices and the fact that their stomach isn't made of steel and they do get symptoms as a result of the food choices that they make, are often way up the scale in terms of making healthy choices. And actually, there is a balance with everything. You can't just eat fruit and high fiber vegetables and not expect to feel bloated or get constipated or whatever because of the roughage volume that you get at the other end.
Yeah, it's all about sort of balance, isn't it?
It always is. Yeah.
And I guess again, sort of, I briefly was saying before we came on about trying to do the whole of gut health in 15 minutes, but when we were in touch with each other and sort of organizing this, a lot of us were following Dame Deborah James and her journey with bowel cancer, and I was kind of quite keen that we would say something. Unfortunately, obviously, she's died since we organized this. But are you finding, maybe this is just not actually true, it's just what I'm seeing, but I just seem to be seeing more young people with bowel cancer. Is that right? Or I tried to look at this statistically and I wasn't seeing it, but I just feel like that's what I'm seeing in my clinics. But yeah,
so what's probably happening is that due to a big public figure like Dame Deborah, who did an amazing job of advertising the fact that the disease is real and it can happen to anybody at any age, and God bless her, but she would have done more for sort of promoting early diagnosis of bowel cancer than any of us professionals could have hoped to do. So I think what you're probably seeing is a kind of effect that because of the awareness that's occurred because of her blogs and things that she's done, and her disease getting worse this year, has been that people have had it at the forefront of their mind. So there's people that had a few spots of blood when they went to the loo, or a new altered bowel habit for 6 weeks that perhaps would have left it 9 months and then presented more spread out across the year. They've probably all come to you at once just because of the time factor. Certainly statistically there isn't any sudden jump in age band. There is the COVID effect as well, which is that we've definitely had more people presenting with later stage cancers than we've seen for a very, very long time, either due to lack of access to diagnostic services or the not wanting to bother the doctor effect as well that we've seen. That's terribly sad. And all I could say in the message to get out there is that there are some very clear symptoms of bowel cancer. It's if you have rectal bleeding, a new onset of the bowel habit, if you have a feeling of still needing to go to the loo when you finish going to the loo, new unexpected weight loss, all of those things should prompt a visit to your GP. And on the NHS side, the GPs have got very straightforward criteria in which they can send patients into the NHS for a scope within a couple of weeks or a scan. And the volumes of referrals to that service have gone through the roof. I mean, we're at Addenbrooke's, we're receiving something like 130 to 140 referrals a week into the GI suspected cancer service, and the baseline is normally around 80 to 90. So that really has gone up. And so I think that awareness has got out there, and there are people coming forward. The other thing about bowel cancer is we have the national screening program, of course.
Yeah.
And the reason we have that is because bowel cancer has a natural history of starting, for the majority of them, in a benign adenomatous polyp, which, if picked up in its early few years of developing, won't have the chance to mutate into cancer-forming cells. And with bowel cancers, but they will produce a bit of blood when the stool passes them. So using sort of a simple stool blood test, and if it's a certain level, getting a colonoscopy, we can remove polyps from people before they have a chance to get to bowel cancer. And so I think it's definitely a disease that should be targeted for eradication, because of the fact that most of it starts as a benign thing that can be taken out, And I know of a prof of GI medicine in the US for Orange County that was hired by the county to eradicate bowel cancer in Orange County, and the things they've done or started doing there, like introducing artificial intelligence into screening programs, and using modern technology and things to and making public awareness higher, is what will do it, because we just need to get people in to get screened and checked. And actually, while having a camera put up your bottom is not the choice thing to do, the procedure itself is incredibly safe. It's not that unpleasant. Some people have very painful procedures when they have colonoscopies. The vast majority don't. And it's such a good test for early detection or pre-detecting pre-malignant, precancerous polyps and things, and getting those removed. And I can't stress enough how, if you pick up a bowel cancer in its first stage, and it's kind of stage 1, the chance of cure is nearly 100% nowadays. So the earlier you get picked up, the better.
Yeah, and I think that's been amazing, and I probably wouldn't say much more, but I think people do sometimes get embarrassed, and that puts them off going. Often someone will come to see me and they kind of are like, oh, this is embarrassing. It's like, well, it's not embarrassing. So it's what we see every day, isn't it? So to be able to come forward earlier is definitely the best advice, isn't it? So that we can.
It is, and we all know, as a professional that works in that area, we all know it's embarrassing for people to come and get those things done. So we create an atmosphere that removes that embarrassment as much as possible. It's little things like, if you come and have a colonoscopy, they get you to put on a special pair of pants so that your bum isn't hanging out, and we try and make the atmosphere in the theatre reasonably okay while you're having it done. Nearly all of my colleagues and I have some music running in the background, kind of like visiting the dentist's office, But I think that the important thing is, if you have any of those symptoms, go and see your GP, if appropriate, get referred to get investigated and sorted out.
Brilliant. That 15 minutes has been and gone, Gareth. It goes really fast, and we probably maybe haven't done justice to some of those topics. But I often say to people at the end, if you've got any questions, please send them my way, and I can obviously discuss them with Gareth. Thank you so much for coming on tonight, and have a nice evening.
Yeah, thanks for having me, Claire. It's nice to see you.